In this video, we'll be demonstrating the technique of managing a patient with ward-off necrosis and disconnected pancreatic duct syndrome using a lumen-opposing metal stent and plastic stents. A 55-year-old male was referred for management of a ward-off necrosis measuring 20 by 18 centimeters. A decision was made to drain the ward-off necrosis using the multiple transluminal gateway technique. A 15mm diameter, dual-flanged lumen-opposing metal stent with electrocautery enhanced delivery system was first inserted. At EUS, the ward-off necrosis was identified from the gastric lumen. The ward-off necrosis was accessed using electrocautery. After positioning the catheter within the ward-off necrosis, the stent deployment hub was released to deploy the distal flange of the stent. This was followed by deployment of the proximal flange within the gastric lumen. The echoendoscope was passed more proximally into the gastric body for creation of the second transmural tract. The ward-off necrosis was accessed using a 19-gauge needle, and a soft tip wire was curled within the collection. The tract was dilated using a graded tip catheter, followed by an 8mm radial expansion balloon. Due to the presence of disconnected pancreatic duct syndrome and the need for indefinite transmural stent placement, two 7 French 4cm double pigtail stents were then inserted through the transmural tract. At 72 hours post-procedure, a repeat CT of the abdomen revealed a 75% decrease in the size of the ward-off necrosis. At 8-week follow-up, the lumen-opposing metal stent was removed. However, the plastic stents were left in situ indefinitely in order to drain the disconnected upstream gland.